Welcome to the Asian Institute of Management. This is part of a series that is run by the school, but this, I believe, is the second or third of the talks or events that are being organized by the graduate students in the school in celebration of International Women's Month. So we're very happy to be celebrating this. Great believer in women. In my own particular career, I've had the privilege of having worked under a number of women bosses, including when I first came back to AIM, my dean was a woman. But I also worked for the only two women presidents of this country. So I'm quite aware of the power of women and do support it. So let me welcome you and then turn the floor over to Mizan, who will introduce this talk and introduce our guest speaker. Mizan?
Thank you, Mike Cruz, Dean of our faculty department. So let us take the privilege of arranging this session up quite a bit different way. So what we were planning to have it, not that much formal structure, rather let us take it in a very informal way, because we have the privilege to have Mr. Pathak with us. He is a very good practitioner, and I guess we have lots of things to learn from him as well. Let me now take the privilege of introducing Dr. Shyam Pathak. He is currently working as the advisor, Health, Typhoon Year-Round High-End Response Program, Save the Children. He was basically a doctor by profession, and then in 2004 he started working with emergency response at Sri Lanka, and now he has been assigned to respond high-end in Philippines. And he is also a fellow of Royal Institute of Public Health in London. And then apart from his clinical work and humanitarian work, he also teaches as a teacher in some postgraduate courses at the Charity Medical University in Berlin. And then prior to the international career, he briefly served a research doctor in Japan. And now he is with us. We will take the privilege of getting the experience of him, especially in the area of adolescent and sexual reproductive health needs in emergency. So let us welcome Dr. Pathak.
Good afternoon. Thank you so much, Dean Mizan, for your kind words. We are really pleased to be in Asian Institute of Management. Thank you so much. Maybe just to give you a quick update about Save the Children, my organization, and what we do. With me, we have some of my colleagues sitting on the front row, and also Abraham sitting on the back row, who is a WASH advisor. Save the Children is a international humanitarian organization. We have been in Philippines since 1981. And specifically now we are here for the Yolanda response. So the team is, you have seen there are a couple of emergencies in Philippines over the last recent years, and out of them Yolanda is the biggest humanitarian crisis. Save the Children is responding in more than 120 countries, and Philippines is one of them. Just a quick update about Save the Children. It has 29 members. Save the Children members, and we work under one umbrella organization called Save the Children International. So all the country programs are under the Save the Children International. By the name, we are Save the Children. That means we focus on the children. Our activities are across the 7 sectors, and out of 7 sectors, health is one of them. So in next 20 to 25 minutes, I'll walk you through the health program, especially with the adolescent and sexual reproductive health and emergencies, just to let you know the Save the Children intervention for Yolanda response, and then we'll have some time to discuss on any questions or feedback from your side. This map clearly shows, I'm sure you have seen this map a couple of times. This is basically the typhoon, the map that we received from the World Food Program to show the direction of the typhoon. It basically hit the 2 islands, Panay and Leyte, The Leyte is most severely devastated in comparison to Penang. Save the Children program focus on the 7 sectors, as I said. One of them is the health, and the other sectors are nutrition, water and sanitation, food security, livelihood, education, child protection, and child rights governance. So now this is basically the field offices which we have. There are the 3 field offices implementing all the 7 sectors program. One is in Tacloban, second in Ormoc, and third one is in Panay. So far, until yesterday, the latest figure we have is we have reached more than 350,000 beneficiaries through the 7 sectors. It is more multi-sector integrated program. So this is being one of the, if you look at the category of the kind of the crisis, this is, as by the UN, it is categorized as a L3. That means the highest level of category, the highest level of humanitarian crisis. And for Save the Children, it is category 1 emergency. So now we will focus only on the health program. What we do on health? The health program started a few days after the typhoon hit the 2 islands. In fact, tomorrow, day after tomorrow, it is going to be 4 months, and we were on the ground from 11th of November. The first mobile clinic that came up in Leyte was 25th of November, and then in Panay on 28th of November. So at the moment, we have 3 mobile clinics in Tacloban, 1 in Ormoc, and 3 in Panay. So the first activity we started was a mobile clinic. It has a medical doctor, which is a GP, general physician, nurses, midwife, nutrition officer, hygiene promoter, and a psychosocial counselor. So far we have reached 29,000 direct beneficiaries or the consultation through these 7 mobile clinics. Second activity we started is the reproductive health medical mission, which is pretty much close to the mobile medical clinic. It is basically focused for the women with the reproductive age and the children. So this is the reproductive mission. Is basically we carried out in the barangays that are identified by the municipality or the Department of Health. So far we have done 6 reproductive health medical mission in one of the municipality in Leyte, and reached over 1,300 patients. Out of them, 50% are pregnant women and remaining 50% the lactating women. The third one is the adolescent sexual and reproductive health in emergency. So our discussion will focus more on adolescent sexual reproductive health in the emergency over the next 10 minutes. Save the Children also supported mass immunization campaign. I'm sure you must have heard about the measles outbreak in different parts of the country, including Manila. We supported Department of Health in December to carry out the mass measles campaign in Leyte, and in total we reached 8,500 children with the polio, measles, and vitamin A. Third one is the essential interpartum and newborn care. This is a training plan for the midwife. As we know, immediately after the crisis or during the crisis, for many reasons, the home delivery is more than the facility-based delivery. And whether we accept or not, this home delivery are normally conducted by traditional birth attendants. So our idea is to shift from traditional birth attendant to have a midwife to train, especially to screen the pregnant woman, identify the danger sign, and at least refer them up to the health facilities. This training is ongoing in Panay. Our idea is to pilot this training in Panay, roll out throughout the island so that we manage to train all the midwives from public and the private sector. Subsequently, we will have the same training module in Leyte, but that will be later this year. Third is the support of the departmental health structure. That means most critical gap we saw during our assessment in December is with the medical supplies, human resource, and the infrastructures. Save the Children is repairing the health facilities. We are doing 11 barangay health station and rural health unit in Leyte and 15 in Panay. On top of that, we are providing drugs, the essential drugs, and some of the kits like cholera kits, emergency hygiene kit, health kits, which is enough to treat about 300 patients with the bloody diarrhea or any kind of waterborne disease. Save the Children is also doing some research, especially to identify the state of mother. There is one research ongoing about the state of mother worldwide, and normally they select the countries which are in the humanitarian crisis, whether it is a natural or man-made disaster. So for this year, we are doing this research in Philippines, and we have targeted 2 islands, Panay and Leyte. Finally, the capacity building, it is an ongoing process. We started training the medics and paramedics both in both the islands, and this process will continue. Just to give you a brief more update on Save the Children intervention on Yolanda response, the response is divided into 3 phases. The first phase began in November last year. It will finish in June this year. The first is more like a rapid response phase, like in any other emergencies, where we provide rapid response with all the 7 sectors. And second phase will focus more on repair and rehabilitation. And third phase is like supporting the Department of Health. However, support to the Department of Health already began in November with the repair, drugs, capacity building. We are also strengthening the surveillance mechanism. As I said, there are the suspected cases of typhoid, dengue, measles coming up from the different part of the country, especially in the areas where we are working. So we are setting up the surveillance system, which is called Health Information System. It is a global system used by the WHO, and it's also used by the Department of Health in Philippines. Now let us speak a little bit about reproductive health, why we are here, and why do we think the reproductive health is very important, especially in the crisis. As I said, for many reasons, whether we accept or don't accept, the number of, I should say, the vulnerability, especially for the girls, and also to the lesser extent to the boys, increases immediately after the crisis. Maybe number 1 reason is the access. There is no access to the health facilities due to the transportation or lack of the transportation. Maybe there is no health facilities. Number 3, if there is health facilities, the health facility may not have enough human resource and essential supplies. So that always increases. These are the medical conditions, and there are some social and economic conditions that increase the risk for the women, especially the young girls. So we focus our program for these young girls, and on top, with our assessment in December, we identified some of the risk factors why the women, especially the young girls between 15 to 24 years, are more prone to this kind of risk. We have done a quick assessment in the reproductive health technical working group, which is functional in the Philippines, and found out that a couple of the indicators in the Philippines are pretty much in the alarming way. For instance, there is a maternal mortality ratio. That means when the pregnant woman, if a pregnant woman dies any time after she becomes pregnant, up to 42 days after the delivery, that is included as a maternal mortality rate or ratio. And the Philippines has the highest maternal mortality ratio in ASEAN region. That means much higher than Singapore, Vietnam, or Cambodia. At the moment, it is assumed that maternal mortality ratio in Philippines is around 99 per 100,000 live births, which is in comparison to other countries in this region is pretty high. And then you will see some other issues, especially with the gender stereotyping and multiple burden. What we see after this is from our own experience in the 2 islands, after the catastrophe, the young boys and girls, they were left either they lost their parents or the house, and there was extra burden on them to take care of the family, to earn the livelihood for the family. So all these conditions, social, economic, and medical conditions, increase the risk for the young girls and the boys. So overall, what are the objectives and the goals of the adolescent and sexual reproductive health? The main objective is to reduce the teenage pregnancy, because normally when they are teenage, that means we are talking about the age up to 19 years, 15 to 19 years, they are mentally, psychologically, physically, and emotionally not ready to take the responsibilities of becoming pregnant. That can not only affect their health, but that can also affect their future. So that will have a long-term impact on the individual life. So we will try to focus to reduce the number of teenage pregnancy. So for that, what we need is provide the information. That means the overall goal is to reduce the number of pregnancy, reduce the number of sexually transmitted infection. One of the issues we have found during our assessment and also research in the Philippines is contraceptive prevalence rate is still pretty low. Among the women, it is still below the 50%, women in the reproductive age. So that makes the woman even more prone to, or let's say more in a risky condition to get the sexually transmitted infection. And third is the HIV and AIDS. There is a different need about the HIV transmission or HIV treatment among the different age group. However, it needs to be very clear that HIV, AIDS Once a person gets this virus in the body, it will stay in the body for the lifetime. It can affect any age group, any background, cultural background, religious background, social or economic background. So this information needs to be disseminated to the youth. Thirdly, about the use of the contraceptives. Contraceptives may not be widely accepted. It depends on the different culture and the society. So the easiest way to reach the youth is to set up a youth-friendly space where they can come and talk about their own problem freely. So Save the Children has started this kind of approach where we set up the youth-friendly spaces. The foremost important is, first of all, listen to them, do the counseling, education, instruct them about the use of the contraceptive, and tell them about availability of the health services. For instance, if an individual becomes pregnant or if an individual has any kind of illness, where he or she should go for the treatment. So these are the basically overall goal of adolescent sexual reproductive health in emergencies. Now let us focus on our activities. As I said, reproductive health mission, it has a similar model like the mobile clinic where we have the 2 gynecologists and the 2 pediatricians along with the nurses doing the outpatient consultation. This is a mobile clinic which goes from one barangas to other barangas which are identified by the local government unit, municipalities and the Department of Health. The Save the Children provide the outpatient department consultation, family planning, counseling. We also provide the temporary family planning devices, do the referral, and also identify the high-risk pregnancy. So if an individual or the pregnant woman is identified as a high-risk pregnancy, that means, number one, very simple for all of us to understand. If a woman comes to antenatal checkup visit, that means medical consultation during the pregnancy, and we identify the high blood pressure, or there is a swelling around the legs, which is very common, that is called edema, or any other medical condition which will put her into the risk. So we take the note of this patient, and she is registered into our system, so that when she is in the 8th month or the beginning of the 9th month, there is a referral system to take her to the health facilities. Save the Children has a referral policy. We provide them our own vehicle to transport the patient up to the hospital. We pay for the caretaker food. We also pay for the transportation back from the hospital up to the home. Second activities, which is very important, which is focused mostly on adolescent and sexual reproductive health. We target the youth and try to get them as a volunteer. So far, we are working in 2 municipalities in Leyte. One is Tacloban, the other one is Ormo. And we are covering the 8 areas in these 2 municipalities. So far, we have set up 7 youth-friendly spaces. The youth-friendly spaces are run by the youth volunteer. We select them from the community, train them by the Save the Children staff, and teach them how to run the youth-friendly space. So basically, this is open every day, where they provide information about adolescent reproductive education, counseling, first aid, how to use the dignity kit. There are different kinds of kits. The dignity kits and hygiene kits are normally provided by Save the Children during the antenatal checkup. And when the woman comes for the postnatal checkup with the child, that means within 42 days after the delivery, she is given a newborn kit. That means the kit is enough for the newborn baby. So we provide the counseling about all these kits, how to use the kit. And then also the psychosocial counseling. Save the Children approach is to have the integrated multi-sectoral interventions. So in that way, we maximize the use of the local resources and have one set of frontline workers. We have already begun this process. Some of the activities are already integrated across all the sectors. By the time we finish our phase 1 of intervention, which is June of this year, we are planning to have a complete integrated approach. Third one is the hygiene kit distribution. The hygiene kits are mainly targeted to the pregnant women when they come for the antenatal checkup. It has served as a very good incentive for them to come for the visit. And the hygiene kits contain the standard WHO package for the pregnant woman. And finally is the maternity tents. Maybe you all are aware, like the health facilities, especially in Leyte, they are damaged. Most of the health facilities are either damaged between 50 to 90%. Some of them are partially functional, a couple of them are still completely destroyed. So what we are doing as a Save the Children is we are setting up the maternity ward, that means the birthing center. It depends on a different language. Sometimes they like to call it as a birthing center or a maternity ward. We are setting up the temporary tent which can serve as a maternity ward where a woman can come and deliver. This maternity tent is run by the midwife who does the normal delivery. In case she finds any high-risk pregnant woman, she would transfer or refer this patient to the hospital which are supported by the Save the Children. For instance, in Tacloban or in Leyte, we support Eastern Visayas Regional Medical Center, which is a tertiary level hospital. And similarly in Panay, we support the Western Visayas Regional Medical Center. It is also a tertiary level hospital. In fact, it is academic institute where the residents are doing their post-graduation. So basically, this is what our activities in a nutshell. And thank you so much. All our achievement in Philippines is possible because of the support from all the stakeholders, including Department of Health, and the very high and rich local resources. Thank you, Asian Institute of Management, and everyone for coming here. If you have any questions, comment, feedback, please. Thank you.
Thank you, Dr. Pathak. I think we are going to put lots of questions to you because there are two reasons. One is that lots of our classmates are going to your areas, I mean the highly affected areas, to do some sort of assessment. This is one thing. And second, we have almost 10 doctors here. So we will now open the forum for open discussion, and Dr. Pathak will answer one by one, not taking more than one question. So please, questions. First, Ryan, please. Doctors first.
Ladies first. I'm sure. Thank you, doctor. I probably just have a general question, a general sensing question. How are the young women coping after the tragedy? Because before we intervene, of course, we feel first.
Well, the first few weeks when we started the intervention and during our assessment, we found out the situation was really difficult. Just to give you one example of my own team, Save the Children team in Tacloban, our team is around 240 staffs, and out of them, more than 70% they were directly affected by Yolanda, and they were also one of the direct beneficiaries of our program. So now they are hired by us. Many of them are still in a kind of stress and trauma. For example, one colleague in my team, the health team, she is a data entry person. She lost her father, and in fact, she is not able to find him yet. He's lost, and there are a couple of very heartbreaking stories even among my colleagues. So this is definitely as I said, category 1 emergency, which has a very long-term impact both emotionally, physically, and also for the local economy. So it has not been easy for the local population to cope up.
Maybe please. Maybe.
You have a list of your intervention. No, but there was another one. Yes. Because we hear stories, but maybe the stories are just specific incidences. So, what is your assessment of how grave the situation is, and maybe the percentages of people affected? I mean, what's the scale that we're talking about here? Because if you look at media, it's like there's huge risk for everyone, and not just risk, there's actual abuse that has happened. But I'm trying to figure out what is the real story versus what is media, just repeating stories, but it's not necessarily, or it may actually be worse than that. But what is the real scenario?
As I said, like from our assessment, which was a more multi-sector assessment than a vertical health program assessment, the information we have is a very top-line information, especially looking at the needs, what is the health needs of the population. And since the health facilities are destroyed, access is a major problem, and socioeconomic burden is pretty high in each family. Even in the meeting with the DOS last week, they came out with the new data that for the economy, it is more than 60 billion peso loss, both for public and the private sector. So it will take at least 5 years for the repair and reconstruction. This is the estimation from the Department of Health. So our findings from the mobile clinics assessment and activities is that there is a huge gap, especially in terms of the service provision and the delivery. The BHS are almost non-functional yet. The primary healthcare service is solely provided by the mobile clinic, but our idea is to have a BHS or the RHU running so that mobile clinic can phase out at the earliest. And we are aiming to do this by the 1st of April. And in April, we are planning to do the CAP survey, which will give us even more clear picture about the magnitude of the damage and also to answer your question more precisely about how many actually are affected and out of the affected population, how many are actually able to access the health facilities.
Okay, President Arman, please.
I had experience with working with Save the Children in one of my pilot projects in Pasay City. We had set up a adolescent-friendly health facility in Malibay. And I was wondering how this strategy differ in that, given that it's a disaster area. So I was imagining, you mentioned that you were helping rebuild and renovate health centers. So I was thinking what really be a special health center like a adolescent-friendly facility. So I was expecting you to showing some slides on it.
Well, with the health center, our primary focus is the health center be up and running, provide the primary healthcare service. For the adolescent, we have set up the youth-friendly space. At the moment, the youth-friendly space are set up in the tents, which is like a temporary tents. What we would like to do is 6 months, that means by the end of June, this youth-friendly center should be transformed either into the hospitals, if there is a space, or health center, or if not in the public place, where the youth can still visit like even in the future, not only until the end of June, even from the 1st of July. That is the reason we have trained the volunteers from the community. These volunteers will continue to work. Save the Children will continue to provide support to these volunteers. Save the Children doesn't pay any cash to the volunteers. What we do is train them and provide some incentives. They might get a t-shirt like us, and it is basically a purely volunteer job for them.
A follow-up question.
Yeah.
Did you also do a capability building for the health center staff?
Yes, we are doing. The recent one we have done is the setting of the surveillance system. Like we train them. We train first of all our health information system officer in each field office, and they are going to each health facilities which are now being repaired by Save the Children, training the staff there. Not only training them, we are also providing the equipment, for example laptops, because this HIS system is a like precise database system which works only in the specific laptops. It doesn't work with all the system. So we are providing logistic support, trainings, and medicines. So these are all ongoing support.
How about awareness campaign, especially infertility awareness?
In other emergencies or in other humanitarian crises in other part of the world, what Save the Children does is recruit or create a set of the volunteers. But in Philippines, since there is already a community health volunteers or community health workers and nutrition health scholars, which are already identified and set up by the Department of Health, we are using the same system. We are using the community health workers and nutrition health scholars. We are training them so that they can go for door-to-door visit, do the community mobilization, identify the high-risk case, not only on the health or on the reproductive health, but also on the nutrition. For instance, we are doing the screening, malnutrition screening. We are using the mass screening procedure, which is called medium upper arm circumference, just to find out the children, pregnant and lactating women, if they are moderately malnourished or severely malnourished. In that case, the volunteers who are the community health worker will at least refer them up to the health facilities which are supported by us. We are using the same referral slip being prepared and developed by the RHU, and we use the same system, same HIS system developed and used by the DOH. So there is no parallel system set up by the Save the Children.
Okay, thank you. Can I come with Nova, please? Come in, Nova.
Actually, it is already answered. I was curious about the sustainability. Those are very good interventions.
Those are very good interventions, but I was concerned about the sustainability of those interventions. What are your ways of ensuring that these would be continued? Because as you know, you have a 3-year engagement, and after that, the development, the NGOs will be pulling out because of limited resources, limited funding. But you sort of answered it. You said that you were training volunteers. But aside from that, do you have other safety nets to ensure continuity of those interventions?
Well, just to begin your answer, as I said in the beginning, Save the Children is in country since 1981, and we are here to support the DOH structures whenever there is a gap. The Yolanda response plan is 3 years. It doesn't mean we will phase out by the end of 3 years, hand over it to the DOH and leave it. Our presence is still in country, and what we are trying to do is develop the longer term partnership with the Department of Health. So, because at the end, it's the Department of Health who has to take care, or who has to take the responsibility to deliver the healthcare service to the population. The international organization, what they can do is to fill in the gap and continue to support DOH, like in terms of capacity building or provision of the essential medicines or the supplies whenever there is a gap. And the most important thing which Save the Children is doing at the moment is developing the emergency preparedness plan, which means we are not only writing the emergency preparedness plan on the piece of paper, making it 30 pages or 40 pages nice plan. It is not that. We are also doing the preposition of the supplies. For example, what we are doing is setting up the warehouse in Manila and also in the field offices that has essential drugs and the supplies. For example, we are prepositioning some of the cholera kit. One cholera kit is enough to treat at least 3,000 cases of cholera or any acute watery diarrhea or any kind of diarrheal disease. So these are already prepositioned. And within Save the Children, we are training our own colleagues, for instance, our health managers, health coordinator, so they can be a part of the rapid response team. So in case there is any other catastrophe coming up next month or the next week or the next year, which is likely to happen given the geographical location, we have a rapid response team within Save the Children who can be the first in the field to respond. In addition, we will continue our support to the DOH.
Thank you for this wonderful insight. I come from Caracas, Belgium. We also involved in livelihood improvement in Panay. I just want to ask about the health policy, how it is affecting you. It's like the traditional birth attendants, they call them healers, they're not allowed anymore to assist birthing. On the one hand, if you see like what we involved now in some of the islands, very inaccessible, no transport. If they have to hire a boat, quite expensive. And if you see one health center having a visit of twice a month by one midwife, that is practically no service, I could say, because what can she do? Twice a month, come and discuss with them. So they have to go to the town and no money. The disabled are a little bit discouraged, though they are hiding themselves and assisting them still. What would you think it's possible? Because when I think about doing something, you need also policy cover. So it's for me it's a big challenge. I just want to hear your experience as a long standing NGO here in the Philippines. Because I was trying also to discuss with the health and they don't have much solution. I thought of also training the healers can be okay. I mean, better than nothing. But how would you see it from all this point? And another thing, it's so interesting about yours. It's again, if you see in most barangays and things, especially in the Catholic community, they are kind of organized with basic Iglesian community and things, and it's a kind of phobia to talk about adolescents, about sexuality and things, and it's also not easy about talking about contraceptive even, I mean, it's quite phobia what I saw in the places where we are. What would you think is better solution to sustain it? To get these volunteers to get more support and protection from the community and the leaders in the community. Thank you.
Well, the first part of your question, I would answer, there is definitely a human resource gap within the Department of Health Structures. Second is the access. Even our experience in Panay, a couple of islands which we support or we serve, it takes a couple of hours by boat to reach those islands. And same with the referral. You are totally correct to say if a pregnant woman at night or even in the afternoon she develops some kind of complication, has to come to the health facilities, is 2 hours by boat. At the moment, what we are doing, Save the Children, is we provide all the referral by ourselves. There is a board hired by Save the Children. But this is, as I said, this is the rapid response phase. So there is a lot of resources being mobilized. The health facilities are still not completely functional. So our support is at the highest level. But what we would like to see, or what we are partnering with the Department of Health, is there is a definite structures and the policy within the Department of Health, so they can take care of all the cases and provide services. Our support would be more to fill in the gap. So even after first phase of our response finishes in June, we will continue to support Department of Health providing the human resources. For instance, the doctors, nurses and the paramedics and the midwife we have in the mobile clinic, they will be assigned to work in the Department of Health structure, which can be Baranga Health Station, RHU or the district hospital. But as I said, this is again a short-term solution. Our intervention would not be maybe for a couple of months or a year. But for the longer term, the MTOH should come up with some kind of policy. For the use of the TBAs, you are totally correct. As I said during my presentation, whether we accept or not, most of the deliveries, especially after Yolanda or after crisis globally and also in Philippines, are happening at home. DOH came up with a very strong policy that every child should be delivered at health facility in order to get the birth certificate. Now this is a big issue of discussion even in the reproductive health technical working group in Manila level, that what will Department of Health or the government will do if the child is delivered at home by the TPA or by midwife or by unskilled human resource or anyone, which cannot be even TBA. So TBA is sometimes even a luxury. There are the people who are totally unskilled delivering at home. So for the time being, DOH has made it a little bit relaxed. What they have said is if a child is born at home, the parents can take the child to the local government unit, register it and get the birth certificate. But I'm sure that will not last for a too long time. They will definitely again encourage the facility-based delivery. But to encourage this, they need to set up the background, like especially in terms of the access, human resource. There are the TBAs in the community. Now our discussion is how to best utilize the TBA. Not to deliver in the hospital, in the home, but rather to use them as a referral center, a referral point. They will identify the cases, pregnant women, whether it's high risk or no risk, and send them to the health facility on time for delivery. For that, we are trying to develop a system where we provide incentive to the TBAs so that they will not deliver at home, but rather facilitate the referral. And also when our community health volunteers goes back to the community, the TBAs can be a focal person to provide the address for the follow-up. And second part of your question about discussion on sexuality and contraceptions, as I said, in many cultures it is still difficult to discuss. In some culture and countries it is still considered as a taboo. But you are an Asian Institute of Management graduate, so what I would like to reinforce through you is sexuality doesn't mean sex. Sexuality means talking about who you are, what you want to do, how people perceive about you. That will be reflected as a gender, whether you are male or female. We know there are gender stereotyping in our society wherever we come from that either inhibits in most of the conditions that pulls back for the individual to perform or to live a productive life. But it is a time for every individual to overcome this gender stereotyping. So he or she knows her or his strength and potential to live as a qualified citizen. So I think this is a time for all of us to advocate for the use of the contraceptive. Maybe it is not easily acceptable in the beginning, which we have experienced globally, but slowly it has to come. As I said, the three conditions First of all, to decrease or avoid the teenage pregnancy. Secondly, to avoid sexually transmitted infection. And third, most important, is to prevent the HIV transmission. Condom is the best, or the use of the family planning devices for the birth spacing, even after the married woman, from the first child to second child. Just to give you a quick update about Philippines. The teenage pregnancy in Philippines, which is between 15 to 19 years, is almost 30% of total pregnancy, which is very high. And teenage pregnancy means there is a high risk of abortion or the miscarriage. That is always number one cause of mortality, infection, and hemorrhage, bleeding. So that means there is definitely a gap. So for us, it's the best to utilize the TVA or the midwife in the community as a focal person for the reproductive. That is the reason why we are doing this emergency intrapartum and neonatal care training, focus only for the midwife, so that they are trained to identify symptoms and signs and refer them to the health facilities. And same with the newborn care. When the woman is discharged from the health facilities, she gets visited by the TVAs or the midwife, who can tell her that what are the danger signs for the newborn. For example, the jaundice, which is very common. For 72 hours, there is a physiological jaundice in many children, so there is no need to panic. Any yellow discoloration after 72 hours should be a clinical jaundice, and the child needs to get to the health facility. So basically, these are all the awareness which is possible only through the community mobilization. And the part of the community is TVAs, midwife, community elders, and most importantly in Philippines is the Barangays captain. And in all the areas we have worked, the Barangays captains are very active, and most of them are females. So it is a high time to empower all the females and the community so that we improve their health saving behavior.
Too many questions, too little time. We are running out of time. Hopefully, we'll be able to pick. So, you have some questions. So, before going to the questions, just once we finish it, we'll have another assignment to do. The News and Dr. Pathak will inaugurate the signing campaign. We will express our commitment for empowering the women and girls. And before that, we will have only a few questions. So, if you please finish, then we can move on.
Okay, thank you for the presentation. I really had two questions. One was, you talk about Department of Health, but the health function has been devolved to the local government. So I'm just curious how the Department of Health really goes down to the regional level, but provincial and city and municipality are now with the local government. Do you find the local governments that you're working, the areas where you're working in, do you find the local governments ready to take on the work? That's the first question. And if not, how do you get them ready? The second question is, based on the targets, you said you were going to reach what, about 1.4 million, something like that. You're now at about 380,000. That looks like it's a slow moving, getting to target seems to be slow. Are there conditions on the ground that make it difficult to reach more people, or is that really part of the campaign, that you're being very deliberate about how you get those numbers?
Well, thank you so much, Leo, for your questions. About the local government unit, like as I said, in other emergencies globally, a couple of months after the catastrophe, we are still in the emergency phase, delivering the rapid response. But in Philippines, we are already talking about the early recovery. In fact, our strategy, we are revising our strategy to focus more on early recovery, and that is all possible due to the support from all the stakeholders. That also includes local government unit. So far, in our experience in both the islands, Panay and in Leyte, we have a very good support from all the local governments unit and also from the regional DOH and definitely in Manila. So all in all, I should say this is the most positive response I've ever seen in the last 10 years, and the support from the Department of Health and local government unit. Secondly, for the target, you said 1.4 million is our total target, and we have so far reached just about 350,000. But this is the total response target, which we will complete by the time we finish the Yolanda response. Certainly, there are some of the constraints, or I should say the challenges during the implementation. For instance, I've been talking about the repair and rehabilitation of the health facilities. That could not begin very early in the response phase. Like 8th of November was Yolanda. We planned to do the repair from the December, but that didn't happen because there was a lack of supplies. Like for example, in Tacloban, we didn't find any materials in Tacloban. So all the procurements had to go either from Cebu or from Manila. And that will not only increase the cost, but also the time. And all the transportation from Manila by road to Tacloban takes a couple of days looking at the traffic. And for the drugs, similarly, like we were bringing some of the essential drugs, and that had, in the beginning, we had all the flight landing in Cebu, which means from Cebu we had to again transport it to the field offices and health facilities in Panay and in Leyte. So that would take time, energy, and the cost. So definitely, we had some challenges in the beginning, but now slowly, as I said, things have slowly moved, I should say, significantly well, and we are more or less on track, especially with all the activities, which is reflected with the number of beneficiaries we have reached in less than 4 months.
I guess John was.
Thank you for your presentation. I was just also curious about how do you see your adolescent sexual and reproductive health engagements different between emergency and non-emergency situations? Since I guess you would have some takeaways as to what would be the learning points that people can learn from this so that the next time it would happen, then could probably prepare well for it. And you mentioned that there are already internal processes happening within your organization. You have plans in terms of rolling it out with, for example, the local government units. I know there are some engagements with the Department of Health in terms of policy, but in terms of the implementation end, you also have certain engagements with your stakeholders.
Thank you so much. This is a very good question, in fact. We are doing the advocacy at all the levels, starting in the field, Manila, and at the international level on the adolescent sexual and reproductive health. Especially Save the Children is very vocal, even in the international level, with the reproductive health. One of the advocacy issue is the integration of reproductive health into the primary health care. That means integrated service from the barangay health station or the rural health unit. We have been pushing DOH, which is very positive, to include this into the primary health care package along with the nutrition and the water and sanitation. So this has moved fairly well. The big challenge, as you outlined, is after the catastrophe, after any humanitarian crisis. As I said, there is a loss of livelihood, first of all, loss of access, no transport, and that will increase more risks to young boys, and not only girls, but also to the young boys, and they are more prone to abuse, or we can see different kind of cases coming, starting with the rape or abuse at the workplace, or even at home or in the community. So for them to address properly, what we are setting up with the BHS We Repair is any case of sexual and gender-based violence that report to the barangay health station, they will be referred to the rural health unit or to the district hospital, because it also has some legal implication. So BHS doesn't have a capacity to be at that. There is a referral form, but the only challenge for us to reinforce or to revitalize this referral mechanism and make it smooth and functional between the barangay health station and the secondary and tertiary level health facilities.
Thank you very much. I think we are running out of time. It is almost 6 and we plan to finish it by 6. So let us clap for Dr. Pathak. It was really I would like to thank you all, the full team from Save the Children, for being with us during the last few moments. So now let us invite the Hindus and also Dr. Pathak to start the campaign. They will inaugurate the signing and then we will follow them. So after that also there is some refreshment. We will also pick up some questions to Dr. Pathak. To you, we will have some more questions during the tea break, definitely. Thank you very much. Classmates and also the guests, please come up join us for signing this